Hello, everybody. Welcome to UroChannel live from Göttingen in the middle of Germany. And I hope you had a nice Christmas. And in some regions of the world, you still say Merry Christmas. I've lived many years in the northern countries, and you say Merry Christmas there for a long time until almost the middle of January. So Merry Christmas to you all who haven't seen my video. I posted on Wednesday where I wished everybody here on UroChannel a Merry Christmas, and I hope that you had a very good time. For some reason, I think also the Grinch watched this video because I got a dislike on this video. It must have been the Grinch, I think. So he doesn't like Christmas. This video or this live stream is about penile curvature. I think it is a good topic because there are so many men suffering from penile curvature. Many men are very insecure about what is normal and what is considered as normal or abnormal. And at the same time, I'm uploading a video tomorrow about penile curvature after radical prostatectomy for prostate cancer. This is a very little known side effect that affects quite a lot of men after this kind of surgery. So thank you everybody who is watching UroChannel right now. Thank you for the subscribers who are watching. If you're not a subscriber, please do so, because then you wouldn't miss out on any new information. My name is Dr. Stefan Buntrock. If you haven't seen me before, I'm a board-certified urologist and also a specialist in sexual health. But over the years, some of you may have noticed I specialized quite a lot, because I think that lifelong learning is something that I very much endorse. So after sexual medicine, I subspecialized in sports medicine, which I think is very important when it comes to sexuality or sexual function, for that matter. And the latest specialization that I have gotten was in nutritional medicine, and that was actually that was last week. I had my exam, so this is some of my subspecialties I have. So I think it's a good thing to have both sexuality, sports medicine, nutritional medicine. Everything of this is linked together and connected. And if you're not a subscriber, as I said, please subscribe, like this video, like this live stream. Don't be the Grinch. And thank you in advance for everybody. I have a membership. I don't know if you know about that. The membership is the above average membership that I've had over the course of over a year, I think. It is called the above average membership because of my most popular video, which is about normal penile size. And in this video, I got tons of comments, and most of them saying, I'm above average. And this is how I got its name, the above average membership. Right now, it's the 6-inch level. We'll see in the future if I will augment it, but it's $1.99 per month. If you want to support me, please do so. So what I want to talk today about is penile curvature and what it is. You know, there are several kinds of curvature, and up front, I have to tell you that in most cases, the penis is not straight. It's slightly curved to one side or the other. Mostly it's curved slightly upward, like a banana. But if you're looking for the angle, and there's such a thing like a goniometer, that's what it's called, the goniometer. That's what we use in orthopedics for measuring bone angles and angles in certain diseases and to assess function. You can also download something like that. I had a video about this once. There are lots of goniometer apps on the internet where you can measure the angulation. It's not easy to measure an angle, actually, because it depends on where you put your goniometer, and then you may get different readings. This is one of the problems we have in Peyronie's disease, where we want to assess the angle of the penile angulation. And depending on where we put our goniometer, it can vary. So if you're talking about like 5-6 degrees difference. This is easily done, but just by moving the goniometer in a certain point. So measuring penile angulation is not very easy. But as a rule, I can say that everything that's below 30 degrees is considered as normal. Then there's between 30 and 60 degrees where we would say, well, this is a moderate angulation, and everything over 60 degrees is severe penile deviation, because 60 degrees has been chosen because normally this is the angle where penetration and sexual intercourse becomes very difficult, or you can't even perform it because the angulation is too much. And the angles that a penis can reach in a pathologic penile curvature is huge. It can reach 90 degrees, like so this is 90 degrees, or it can even be 100 and 110 degrees. All of this is possible. And then you can also have changes in rotation. It's not only that it bends upward or downward or to the side. Mostly it bends upward, but sometimes it bends to the left or to the right. And if it's bending downward, this may be special cases which I'm referring to in a second. But then it can also rotate. So you not only have a bending in one direction, but it can also rotate in either direction. And if you're experience such a problem, then the urologist who's assessing this, they should check whether there's a rotation as well, or if it's just a simple angulation. So if you just start with what's hereditary, sometimes development, especially in the genitals, can be hindered by certain things. It can be either that the opening of the urethra is displaced. It's not at the tip of the penis, but it can move slightly downward, like it's a bit underneath. It can even be, the opening can even be a midshaft. We call this hypospadias. It's one of the most common hereditary things we see in penile deformation. Then along with this, you may have an uneven development of the corpora fibrosa, corpora cavernosa, or you may have some things with the prepuce, or even some adherences and everything that bends the penis. Commonly, this is what we call Chordee. That's the technical term for it. Chordee is normally a bending downward of the penis. So a young man, a boy in adolescence, where they get their first erections and they notice a downward bend that has been there as long as they can remember. This is a hint of Chordee. Normally, Chordee would be picked up because it's so common to occur alongside with hypospadias that the pediatricians will pick it up when they do the examinations. So in most babies, Chordee is noted, or even the displacement of the meatus, the opening of the urethra. This is why many of these cases are operated at a young age. So it's 12 to 18 months they are operated. Sometimes they are not noticed, and then one has to talk about whether this should be operated or not. And then again, it depends on angulation. And I think very much it depends upon the difficulties the individual has with sexual intercourse. If it's not a problem, I would just leave it. I think generally no unnecessary surgery on the penis, and cosmetic surgery, I'm not opposed to cosmetic surgery, but I think one has to know what one is going into. And especially when we're talking about small penises or perceived small penises, you have to know that most men wanting penile enlargement surgery, they have normal sized penises. And what most men, this is referring back to the video I was referring to, my most popular one, most men overestimate the size of a normal penis. It's much smaller and much shorter than most of you would think. And this is why there are so many men wanting penile enlargement surgery who have normal sized penises. I had one case which was almost tragic because this man, he thought he had micropenis, but micropenis is a condition that occurs very rarely. It's 2.5 deviations, standard deviations below the average. And this is very small, and only a very small subset of men have this. And this guy had a normal-sized penis, and he wanted penile enlargement surgery. I was very much opposed, but he didn't listen to me. So he went ahead and got penile enlargement surgery. You know, they cut the ligament that anchors the penis towards the pubic bone, and then it's kind of comes out of the body 1 or 2 centimeters. That's about 1 inch. I think more would not be fair to say you would gain if you go on the internet and look at homepages. I see 6 centimeters is normal. No, I don't think so. But anyway, I told this guy before he did this that my opinion that this penis was normal, and I was asking him whether he would be willing to undergo surgery despite the risk for functional loss. And I asked him, would you suffer erectile function for having a larger penis? And this guy said, yes, no doubt about that. I'm all in. I go for penile enlargement. So he went ahead, and then, yeah, his penis was slightly longer afterwards, but he didn't have any kind of erection anymore. So he was experiencing total erectile dysfunction, and that made him very unhappy. Despite having said beforehand, I don't care, I just want a longer penis. But now he had a slightly longer penis and no function. So it's think what you wish for and really think it through. And this is the same with penile curvature, because if you have a slight curvature and it's functioning and functional, I wouldn't go for any kind of surgery. This brings me to the next point, which is Peyronie's disease. I have a lot of videos about Peyronie's disease on my channel. I have a playlist. I can't link it to you right now, but if you can go on my landing page on UroChannel on YouTube, and then you can click on the Peyronie's disease section. There are lots of videos about Peyronie's disease, what it is, how it comes about. Frankly, we don't have an exact answer to that. We know there are some guys who have this hereditary. It is linked to what we call Dupuytren's contracture, which is a disease that can be seen in mature adults. And this goes like this. You can't extend the last 2 fingers of your hand. So if you shake somebody's hand like this, you will notice they can't extend the last 2 fingers. This is called Dupuytren's contracture. And this is linked genetically to Peyronie's disease. And Peyronie's disease is a condition where the structure around the cavernous bodies of the penis, which is called the tunica albuginea, which sits around this like a sock, it becomes inflamed in a certain spot, which means that inflammation means hardness. It's not elastic anymore. And then when the penis expands during erections, this spot is so hard and rigid that it doesn't extend, and this is like a hammock, and the penis goes in certain directions along this hardened nodule. Normally you can feel it. Peyronie's disease is, in most cases, it's palpable. You can't always see it upon ultrasound, because sometimes you get calcium inside this nodule, which we call plaque, which we then call a calcified plaque, and this can be seen upon ultrasound. It looks plain white. Otherwise, you wouldn't be able to see anything. Sometimes you have calcified plaque, sometimes you don't. And Peyronie's disease is, as a rule, is a disease that most men acquire during the second half of life. I have seen 2 cases this year in young men. It happens, but it happens rarely. Which brings me to the other causes of Peyronie's disease, which can be trauma. We think that trauma during sexual activity can cause this. I interview many men, and lots of men tell me when they had sexual intercourse, then it hurt, but then, okay, it was gone. And then a couple of months later, suddenly the penis started to bend. That could be some of the occasions where you could acquire the Peyronie's disease. Or later in life, when diabetes kicks in many, diabetes may be also a factor that's connected to Peyronie's disease. So the treatment that is the standard of care in Peyronie's disease would be surgery or nothing at all. I think it depends on the curvature. If it's still functional, if there is still erectile ability, because in Peyronie's disease, erections, they also suffer. Also, penile length will suffer. But if this is still working somehow and penile curvature is still working for sexual intercourse, then I would just leave it. I wouldn't go for an operation, frankly. If you want to do an operation, I would wait for at least a year and a half, because this inflammation is ongoing for at least a year and a half, maybe 2 years. And before you start thinking operation or surgery, you should have no change in curvature for 6 months. Because then you can be sure, okay, now it has come to a rest, now we can operate. You don't want to do surgery on Peyronie's disease that's still active, because then you have a straight penis for a while and then it starts to bend again. And this is a nightmare. You can't operate this thing twice. There are some risks associated with surgery. So function, as I said, function is a bad problem. Most of these plaques, they sit on the back of the penis, which we call dorsal. And that's the part that's closest to the belly. And that's not so good, but they have a tendency to appear underneath the nerve and the vessels of the penis. And if you cut those, or if you damage those, then you will have a problem in functionality. And this is one of the dangers in surgery, as well as that the penis may become shorter during surgery. There are certain and several techniques which you can apply. I won't go further into detail. You can, in severe cases when there's erectile dysfunction, you can even remove the corpora cavernosa and put in a penile prosthesis at the same time. These are the things that you can do in Peyronie's disease, which is the standard. And this is when you look at the guidelines, this would be considered the standard. You wait until it comes to a rest, and then you operate on it. However, I know that many patients are not very satisfied with this approach, because they don't want to sit at home for a year and a half and watch their penis go more and more in crazy angulations. And the question is what we can do to bring that thing to a halt. And also, I think one has to take into consideration that erectile dysfunction is a common side effect of this disease, and sometimes even cold gland syndrome or soft gland syndrome, which is mostly due to the constriction that happens in Peyronie's disease. You see these hourglass-shaped dents in the penis, so to speak, in the shaft, which constrict the penis, and some are so unlucky that they get these problems with the glands, so the tip of the penis that is not erecting anymore. And this is a big problem, also a side effect. Then there's also penile shortening. The worst case I have seen was flaccid 6 centimeters. Oh, that is a lot. I mean, that was a huge penis, but I mean, 6 centimeters. Normally it's 2 centimeters, 1 to 2 centimeters, like an inch or so. I think 6 centimeters would translate into something around 3 to 4 inches, if I'm not mistaken. So that's a lot that you can lose. So my goal when doing conservative treatment is first try to stop that, try to preserve erectile function, and then try to restore penile length. These are my principal 3 goals that I apply. And then if we are lucky, we can do something for penile curvature. I know that in science, or people who deal with Peyronie's disease, they go all in for curvature because that's the thing that's bothering most. But I think the other ones are equally very important goals, especially because conservative therapy may not be that effective as many want. And it depends a little bit upon the individual case. I've had cases where also curvature was restored, but this is not the rule. As a rule, I can stop this and I can preserve or even increase erectile function and also restore some of the length. So my approach is a combination of several treatments. So I do traction. I think traction is absolutely crucial in anything that one does. And then there is PD5 inhibitors, especially tadalafil, which is a PD5 inhibitor. If you've never heard about this, you know this stuff. This is called Viagra, Cialis, whatever. We call them PD5 inhibitors because of this thing that's called phosphodiesterase 5, which is an enzyme that's active in the penis during erections. And we block that. And this is the mechanism why these kind of drugs work. So you're not getting sexually aroused. It just stops that enzyme. And maybe some of you have this misconception. I see this in my patients still, that some think that they will get aroused by this kind of drugs, but you don't. It's just that you block an enzyme and then the erection can go on. But anyhow, this drug also interferes with molecules that we hold responsible for this chronic inflammation to go on. And this is why I'm using this. It's not principally not for erections, it's for stopping that kind of infection or inflammation. It's not an infection, it's an inflammation. And to bring that to arrest, because that's a pathological activation of an inflammatory pathway. It's not stopping until 1.5 years in the future. So we want to bring that to a stop as soon as possible. And I also combine this with antioxidants, L-arginine, citrulline. These are the basics. And then it's traction, and then we have to see whether it may be a chance to do something with shock waves. I apply shock waves in non-calcified plaques because I see that they soften up these hard nodules, and then you could put traction on them. The same goes for PRP, which is platelet-rich plasma. All of this is derived from your own blood. I draw some blood, and then it's getting into a special kind of centrifuge, and then it's injected into the plaque. But I don't think that any of these will work without traction. So traction is a crucial part of this. And I'm a fan of traction devices. I don't really like the vacuum pumps because I think that first of all, if angulation is very severe and you use a vacuum pump, then you will have a problem with the tube because it's straight and the penis is not. And also that you can't use a vacuum pump forever. You can only use it for a couple of minutes at a time. And heavy vacuum pump users, they have a penis that's looking quite funny, because I think it's more like a Smurf penis because it gets some kind of bluish tint to it. So let's see what I've got. I see there's some questions. There was somebody who's had Peyronie's disease for about 3 years before surgery, quite bad. Surgeon did a great job removing part of the scar tissues. Penis is back. Yeah, that's the. It's a good story where we had a good result. So if it's this way, that's why it's the standard of care. But not everybody is willing to do surgery. That's also one of the problems I see, because I recommend my patients to do surgery. So I tell them we try to stop that and see where it's going, and then we can do surgery. But many men are very reluctant to do surgery in the first place. Yeah, that's my current approach so far. And once in a while, I publish or I upload a video about how it's going and what I see. I've also used radiofrequency therapy. Some of you are still asking about radiofrequency. I still recommend it. I think it is a method well worth looking at, also when it comes to erectile dysfunction. But still, we don't. It's not approved by the FDA. But as far as I know, there are some trials running right now in the US to make it approved by the FDA. And in non-calcified plaques, so far, I have to be honest, I've seen one patient improve on curvature on radiofrequency, but then I don't hear so much, because I know that many are using radiofrequency and they don't report back to me how it's going. So some of my experiences are from firsthand from the patients that are treated here in my office. But I know from the devices that are out there, there are over 5,000 in the world right now, that some other practitioners also see some improvement of radiofrequency therapy. So this may be one of the other things to use. I want to move a little bit from Peyronie's disease to another kind of disease, the third one. But before I do that, it's about tomorrow's video. You will see it in this video, but I'm going to tell you anyway. There's a rather unknown side effect to prostate surgery when it comes to prostate removal because of prostate cancer. I'm only talking about prostate cancer. I'm not talking about TUR. I'm not talking about prostate resection. That's a totally different story. I'm talking about big operation, several hours, prostate out. And you know, when you take the prostate out, you have a gap and you have to close that gap. So the bladder neck gets narrowed into this gap, and then you have to sew it against the urethral stump that's there, because the prostate is part of the urethra, of the tube that carries the urine. And I had 2 patients this year presenting with penile curvature as a side effect of radical prostatectomy. And both of them, funny enough, they didn't have palpable plaques, which I think is very interesting. And this is why I made this video. First of all, according to research, we could say none of the patients are aware of this side effect that can happen after radical prostatectomy. The data that we have tell us that up to 16% of the patients who undergo radical prostatectomy develop penile curvature within 3 years after the operation. And I think that's a lot. That's 16%. It's rather unknown. I don't know why this is, but patients don't know about it. And I'm not quite sure if every urologist is aware that this may be one of the problems. Maybe they don't talk to their patients about this issue afterwards. And, you know, there's also a lot of erectile dysfunction involved. I would say maybe all of this is not becoming visible because of the erectile dysfunction, then it doesn't play a role anyway. But 16% can happen. And there's one study that I found, because of the fact that I didn't feel anything, so I didn't palpate any nodules, so I was very curious, is anybody else seeing this? And I found a study from 2000, which is almost 25 years old, but they found a subset of 31% where they didn't palpate any kind of plaque. So the penis was bent, but they couldn't verify any spot where they would say, okay, here's the problem. Which brings me to the last of the 3 reasons for penile deviation, which is also very unknown. It's Kelâmi Syndrome. I do a video about Kelâmi Syndrome next week, and I have the script ready, and I will record it sometime during next week. Kelâmi Syndrome is a scar tissue fibrosis kind of thing, not in the corpora cavernosa, but in the corpus spongiosum. You know, we have 3 of these corpora, and the corpora cavernosa, which these are the ones who are responsible for rigidity. When you get an erection, they are the ones you use. and these are the ones who have this tunica albuginea wrapped around. And then you have the corpus spongiosum. The corpus spongiosum carries the tip of the penis, the glans, that's part of the corpus spongiosum, and also the urethra runs through the corpus spongiosum. But for rigidity, for the penis to erect, the corpus spongiosum is not that much of importance. So it's the corpus cavernosa. But if you have some problem in the corpus spongiosum, you can likewise develop penile bending. So you may ask yourselves, how do I get that? And usually it's inserting objects into the urethra. This is why I'm not happy with certain procedures. It can happen like if you place a catheter, which sometimes you can't avoid placing a catheter. So this can cause some damage, which then can cause penile bending because of that. You can, if you have urethral stricture, and stricture surgery can cause that. These kinds of problems. Then if you do transurethral surgery, it's not common. Like now we're talking prostate resection. More common is urethral stricture. But in rare cases, it could also develop. And then you have these self-inflicted things. And I'm talking about things that you insert into the urethra because of sexual practices that you may have. So it's you think it's an erogenous zone, or you find this arousing to put something into your urethra. This well may be, but I am very skeptical, because I think you should keep your hands off. If you can't avoid doing procedures on the urethra, okay, then you have to do it, but don't place or put anything into your urethra without a clinical or medical need, because this is very delicate structure. Don't do any piercings or stuff like that. That might also cause this. So this is Kelâmi syndrome. And getting back to radical prostatectomy, I was asking myself, okay, could this be Kelâmi syndrome in these patients where I don't palpate a nodule? And frankly, I don't know. Nobody knows. I couldn't find any data or any article on this. And this is how far we go with our knowledge. So maybe, I don't know, because you as I told you, you are in the bladder neck, you cut out the prostate, you're interfering with this area. This could be a reason for scarring of the corpus spongiosum somehow. And maybe this is one of the reasons, but I'm not sure. I don't know, and maybe we know someday, but right now I'm not quite sure about it. So these are the three reasons for penile deviation. Let's see some questions. Yes, there's one question about traction devices. Maybe you have come to this to my talk a little later. I was talking about stretching devices. Yes, I think they're essential when it comes to Peyronie's disease, because they are able to restore some of the length that you have lost. Problem is, these traction devices have their limitations when it comes to their functionality. Like, how do I put this? I see some drawbacks in every model. There are some kind of models, there's certain kinds of models that are on the market. So there's one model that's like a tray. So you put your penis onto a tray-like thing, and then you have some rods going alongside each side, so left and right. And then you just elongate the rods while the penis is held in place by it's a silicone band that you put over the penis on this tray. This works in medium-sized to large penises, but it's not that much effective in smaller penises because they have a tendency to slip. I had one patient who had a very loose foreskin, and it just wouldn't hold. It would slip all of the time, so this device wouldn't work for him. Then we have devices where you have a vacuum that you put on the tip of the penis. I like these because you could really draw from the end of the penis. But they changed the composition of a rubber. It's like a sock that you place over the glands of the penis so that you can insert it. And they used to have 3 sizes, but they changed that to one size fits all, and it doesn't fit everybody. And I had some patients who were complaining about this because now it's more rigid. It's not as sticky. It's not as easy to put on, and they had some problems with this. But most patients get along well with this kind of device. And then you have a device where you have some kind of girdle that you strap around your waist, and then you can draw from this. There is also a sock-like device, and if you watch the video, they just open 3 fingers and place this over the glands of the penis. But if you've ever done this, it's not working like this. Sometimes the patients come bring their devices and they ask me to do it, so I know firsthand how it feels like to put this over. And this is very rigid in this company. I don't like it because you have to have a half erect penis to put it on. And if you don't have that, or if the erection ceases, it's impossible to put this on. And I have had patients who couldn't use it because they just couldn't place the sock over the glands of the penis. And then you have one device which is from the US, which I like because it reduces the times that you have to stretch. But here you have to clamp the tip of the penis. So there is almost like an adhesive band that you wrap around the tip of the penis, then you place it and you squeeze it. It's like you screw it with 2 plates, and it's kind of flat, the glands, and then you can bend it in every kind of direction. But the advantage is you don't have to use these much stretching times. It's half an hour to an hour if I don't quote me on this one, but it's very short, whereas the other ones you have to stretch up to 8 hours a day. That's a lot. And especially during the night, you could do it during the night, but then it would interfere with nighttime erections, and this is painful then. So it's kind of like a hobby. If you're doing stretching, it's at least 3 hours a day that you have to do it. So it's difficult with stretching devices. Okay, before we come to an end, I just saw another. Yeah, how effective is propolis, vitamin E, diclofenac. Diclofenac is in the guidelines. It's an SSRI, which is usually a painkiller, but it's also anti-inflammatory, and it's used for pain. In the beginning of Peyronie's disease, sometimes people feel pain when they have erections and they wake up during the night because of the pain that's happening. So diclofenac can be something that you can use for a limited number of days. I don't recommend it for more than 10 days because then it interferes with your stomach. So for pain purposes, it can be used, but I wouldn't use it long term. It's a short term thing. Then vitamin E, it's out of the guidelines. It's no longer recommended. The same with Potaba. It's neither recommended. I'm not particularly a fan of vitamin E because of one study that's getting old now. It's the Vitamin and Lifestyle study, which had a huge collective of people, and there were also vitamin E was one of the vitamins that was used. I mean, you have studies for this and that, and sometimes it shows some effect and sometimes it doesn't, but high dose vitamin in this particular study came out with an increased risk for cardiovascular events. So I'm not very happy about this. So I use L-arginine and citrulline. Propolis I don't use at all, and there's a thank you. Okay. So you can rewatch this live stream tomorrow or the next days. Thank you very much for watching. Next week is it's the new year. It's 3rd of January. So I wish you a happy new year, everybody who is watching this, and above all, a healthy 2025. And some nice days before that. We call this in German, I don't know if you had this in English, we call this in between the years, zwischen den Jahren. And I think this is a very special time because it's not quite 2024, it's not quite 2025, it's very calm. I've closed my office right now, so I will reopen on January 3rd. And it's a nice way to calm down and come to a rest at the end of the year. I really like this time. So have a good night, have a good day wherever you're watching from, and see you next week. Bye-bye.